Hello, everyone. This is the time to learn about orthodontics easily while enjoying a cup of coffee. I'm Senior Ortho Barista, Ji Dae-kyung.
I'm Junior Ortho Barista, Lee Jong-guk.
In previous sessions, we've explored orthodontics, clinical cases, and clear aligners in a technical manner. In today's session, we're going to discuss something to think about: effective communication with patients. But before that, let's have a cup of coffee.
Today's coffee is brought to you by Ortho Barista. When you think of coffee, there's one place that cannot be missed. Today, we're heading to Italy.
In Korea, when people think of coffee, Americano often comes to mind. But in Italy, coffee usually refers to espresso. Dr. Jong-guk, do you like espresso?
Well, I have a bit of a childlike palate, so I don't usually go for bitter flavors.
I tend to prefer sweet drinks, sweet coffee in particular. That's right, many people find espresso challenging because of its bitterness. So today, let's take some time to get friendly with espresso.
Today's coffee is Espresso con Panna. In Italian, con means with, and panna means cream. Let's make this coffee today.
Take 40 milliliters of fresh cream and 4 grams of sugar and mix them with a hand mixer.
This reminds me of the past, making dalgona coffee.
Was this during practice exams?
No, it was back when we made dalgona coffee. Alright, it seems ready.
Now, let's brew the espresso.
모양은 예쁘죠?
Let's give it a taste, shall we? Oh, it's really good. How is it? The sweetness, the rich flavor, honestly, personally, it's just... Truly delicious.
What was this gesture?
They say in Italy, when something is too good, people don't say a word. Let's do this together. Let's mess it up together.
Is this really how it's done?
We really shouldn't improvise clumsily. Well, if the title is a bit special, then it's special. Up until now, we've mainly shown you clinical cases, technical aspects, and even clear aligner techniques. But today, we're going to cover something more delicate: communication with patients and what to be cautious about in these interactions. Explain beforehand, or it becomes an excuse afterward. At the beginning of last year, I received a letter from the court. It was referred to as a petition. It really surprised me. It turned out it was about one of our orthodontic patients who had undergone a cosmetic surgery procedure. They were requesting additional materials related to their orthodontic treatment, something like a reference inquiry. Personally, I was very shocked.
You would be surprised. Even if I receive something from the National Tax Service, I get startled.
Generally speaking, dentistry includes obligations to inform patients, and this is especially important in orthodontics. Whether it's an orthodontic specialist or a general practitioner handling orthodontic treatments, I think it's crucial to be aware of these obligations.
We often think these things are just common sense, and they are. They are common and expected, but failing to communicate just one thing can lead to significant misunderstandings or even distrust. That's why I think it's a good idea to meticulously review such matters during this session.
The Korean Association of Orthodontists has shared guidelines about what orthodontists should inform their patients. We plan to highlight key points from these guidelines, using visual materials to explain them. It's a good idea to review each numbered item step by step. These sections about patient consent forms are outlined in detail by the Korean Association of Orthodontists. How do you approach this?
While there's an obligation to inform patients, I want to emphasize the importance of continuously reminding patients about related risks during the treatment process.
When discussing matters with patients, professional terminology often comes up, and they may not remember everything. It's essential to keep records. Back in 2004, I remember looking at some designs. How do they look?
Do they seem up to date for 2024?
Thank you. At the entrance of our clinic, there's a sign that says, "Truth and Trust." Earlier, we talked about patient communication and rapport building. I think this is an essential part of forming good relationships with patients. Writing consent forms repeatedly is less important than effectively addressing key themes. For example, issues related to cavities, gums, root resorption, jaw joint relapse, or problems arising from improper use of devices should all be explained to patients beforehand. It's a good practice to inform them of these risks and obtain signed consent. I believe this is common practice for dental professionals performing implants, minor surgeries, or prosthodontic treatments.
Generally, the side effects of dental procedures appear at the time of treatment or within a short period. However, orthodontic treatment often spans 2 to 3 years. So it's even more important to ensure patients are aware of potential risks throughout the process. The Korean Association of Orthodontists provides abundant resources on this topic. While it's essential to understand and inform patients about these matters, the question is how to communicate them more efficiently.
Let's explore this further. One of the most common complaints from patients is about the black triangle. While the term complaint might sound negative, patients are often familiar with this term.
They even refer to it as BT or BUT.
I recall a time when a patient mentioned short form and I didn't understand what they meant initially. Anyway, the shape of the teeth, or reasons like retraction during backward anchorage, can contribute to this issue. One common approach is called IPR stripping. To reduce the space between teeth, interproximal reduction, IPR, is performed by adjusting the most prominent contact points. For maxillary teeth, this involves shifting downward or upward, and for mandibular teeth, it means shifting downward to reduce the space. This is typically done when correcting crowding, which often creates such spaces. In cases like this, even though there's some space visible with crowding, the amount of crowding may not seem too significant. However, in severe crowding cases, the teeth can look very tightly packed. Resolving crowding often results in the formation of black triangles, or what some patients call BUT. Next is alveolar bone resorption, which can also lead to the appearance of black triangles when it occurs.
If the teeth were rectangular, this wouldn't happen, or at least it would be less noticeable. However, because teeth are often triangular in shape, this issue is almost inevitable.
This ties back to the earlier topic: explain it beforehand, or it becomes an excuse afterward. It highlights the importance of understanding and informing patients about potential outcomes in advance. As shown in the photos, black triangles can appear during retraction after extractions. One way to address this is by using resin buildups. In this case, there's significant crowding. While the teeth may appear tightly packed, the improvement involves a combination of factors. The triangular shape of the teeth, retraction after extractions, resolving crowding, and derotation all contribute to the formation of black triangles.
From the patient's perspective, this can be quite surprising. Patients may mistakenly think it's due to faulty orthodontic work. Of course, how we approach treatment plays a role, but the degree of crowding based on the patient's age should also be considered. By reviewing initial photos, we can predict the likelihood of these issues arising. These things should be communicated in advance so that we can reduce any misunderstandings or difficulties caused by them later on.
That's right. So, it's possible for these things to happen. And for example, in such situations, efforts can be made to reduce the issue through IPR stripping. We could also try to resolve the treatment through resin. This is how we should approach it. Even without orthodontics, misaligned teeth can cause black triangles. These can often be resolved through adjustments or treatments like resin applications, which provide effective solutions in such cases. This is 3 incisors case. This case involves the extraction of a single anterior tooth. You've likely tried 3-layer systems before, haven't you? Teeth can cause black triangles. As I mentioned earlier, predicting such outcomes allows us to prepare and address these concerns with patients.
By showing examples like this, we can explain that black triangles are not necessarily due to orthodontic errors but can result from multiple factors. Through active efforts to mitigate them, we can minimize related issues.
Next, let's discuss temporomandibular joint issues. TMJ issues are another concern patients often raise. Since orthodontics involves the movement of teeth within the oral cavity, patients may experience discomfort in their jaw during treatment. The Korean Association of Orthodontists officially states that there is no direct correlation between orthodontic treatment and TMJ disorders. We share a similar perspective.
While this may not be very common, we believe it's important to inform patients about this possibility, so we've included it here.
Orthodontists with substantial experience may have encountered this issue more frequently.
Of course, you likely have more experience with this than I do, but this shows the difference between before and during treatment. Honestly, it's possible to predict outcomes like this from the initial consultation with the patient. If you look at the gums, you can notice some bulges. To explain the terminology, while there are several terms used, the most common one seems to be alveolar bone exostosis. This condition is also referred to as exostosis, protuberance, or spicule for sharper protrusions. However, the term exostosis is most frequently used in research. There are numerous studies and papers on this topic. Let me share some cases I've encountered. For example, in patients undergoing extraction-based orthodontics, the bulging of the gums becomes noticeable. In such cases, 2 concerns often arise. First, whether the teeth will move smoothly, as the dense bone might prolong the treatment time, and second, whether the bulges will become more prominent. In the maxilla, for instance, there's often an excessive or muscular appearance in the gums. True to expectations, the bulging tends to increase during orthodontic treatment. We always inform patients about this possibility. We show photos like these to explain that this is not a pathological problem but rather a part of the bone remodeling process. If you review the patient's initial photos, You can often observe protrusions in the alveolar bone, which suggests that these bulges might develop during treatment. Extraction-based orthodontics often involves significant tooth movement, which increases bone changes in the surrounding areas. Here's a photo taken during treatment, showing the progression. Some suggest these bulges form due to the movement of the teeth or as remnants of old gum and bone positions. Both explanations seem plausible. Regardless of the cause, these bulges can appear during or after orthodontic treatment. Another patient shows similar protrusions in the gums. Not all patients develop these bulges, but they are more likely in cases where there are visible initial signs. For patients with significant tooth movement, such as during extraction-based orthodontics, the gum bone may become more prominent. This pattern helps us predict the likelihood of such outcomes. In this case, the patient underwent extractions, and during the leveling and retraction process, these bulges formed. Without prior notice, with significant tooth extraction, or, in some cases, even suspecting cancer.
I've had patients return, worried about such issues due to a lack of explanation beforehand.
Miscommunication can lead to mistrust, so it's crucial to address these possibilities up front. These changes aren't necessarily due to incorrect orthodontic treatment. Anyway, before starting orthodontic treatment, patients should be informed that their gum bone may become slightly bulged if any signs appear, so it doesn't sound like an excuse later on. Without orthodontic treatment, bone changes can also occur naturally or as a result of functional pressures like bruxism or clenching. So, rather than saying these changes were caused by orthodontic treatment, it's more accurate to say that orthodontics applies stress to the teeth, which is transmitted to the alveolar bone, potentially leading to bone remodeling. This case also involved extraction-based orthodontics, and you can see significant bulging in the gum area.
Based on experience, it's clear that such outcomes are part of the process in certain cases. In low-angle cases, particularly those with well-developed masseter muscles near the temporomandibular joint, and in cases of deep bite, it's hard to say what comes first or which is the cause and effect. In such cases, even in extraction-based orthodontic patients, the treatment takes a long time and is not easy.
The more we perform orthodontic treatments, the more challenging it seems to become. Wouldn't you agree?
That's right.
What do you think?
I feel the same.
There's about a 10-year difference in our experience, and I respect you for that.
I'm always trying to maintain good relationships with my patients.
Your exceptional rapport-building skills are truly admirable and enviable. Moving on, let's talk about discoloration. I encounter cases of discoloration about once every 1 or 2 years, so it's not very common in my experience. How about you?
It's rare for you as well, I assume.
Frequent cases would indeed be a concern, as it can make orthodontic treatment more challenging.
That's right. Although it's not very common, sharing the possibility with patients and informing them in advance is important. Discoloration often involves tooth devitalization, which can cause fear among patients.
If a patient experiences discoloration or devitalization following orthodontic treatment, it could lead to misunderstandings and significant disputes. To clarify, I've referred to guidelines that state such pulp damage can occur without an identifiable cause. This is not due to the practitioner's error but rather an unpredictable side effect. Let me share a case. In this case, after applying force, the tooth discolored. This was a patient from 7-8 years ago, and at that time, I hadn't informed them about this possibility. Fortunately, the patient received root canal treatment and accepted the situation without issue. However, without prior explanation, such incidents could lead to disputes or accusations that the treatment caused the problem. In some cases, discoloration occurs but later resolves on its own. Recent studies suggest that orthodontic treatment doesn't directly cause pulp necrosis or discoloration. It is thought that temporary discoloration might result from reduced blood flow during treatment, but this often resolves. These studies also indicate that appropriate force typically avoids complications. However, determining what constitutes excessive force can be subjective. When discoloration or pulp necrosis occurs without symptoms or active lesion, monitoring and reducing the applied force often leads to improvement.
Nevertheless, orthodontic treatment requires careful monitoring. For example, when working on the maxillary or mandibular anterior teeth, it's crucial to assess the proximity between the tooth roots and cortical bone, especially in cases like Class 2, Division 2. The applied force and potential trauma from occlusion during treatment should also be considered. During treatment, I occasionally inform patients and make minor occlusal adjustments. The fifth topic is root resorption, which is undoubtedly concerning. Cracks, fractures, resorption, and pulp damage are very concerning topics. From our perspective, we aim to correct the teeth, but there's a risk of tooth loss. That's a scary thought. These concerns can make both practitioners and patients hesitate about starting orthodontic treatment. This is why, as we've emphasized, explaining these risks thoroughly to patients is a crucial skill. Root resorption is a naturally occurring phenomenon during orthodontic treatment to some extent. Typically, it doesn't significantly affect the vitality of the tooth, so patients need not worry excessively. However, orthodontists should carefully assess cases with potential risk factors. For instance, if the tooth roots are short, if the patient has had prior orthodontic treatment, or if they are undergoing retreatment, these are factors to consider. Another is when the root ends are rounded or when there is no crowding, but significant retraction is required. In such cases, the force intensity must be handled with extreme caution.
Root resorption is, unfortunately, a relatively common issue we encounter, while the severity varies.
It is more frequent compared to other complications.
So, what should we do when it occurs?
Based on guidelines, if root resorption is observed as an active issue, it's recommended to use passive wires for a month or two. However, completely removing the wire is not advisable, as it could lead to further resorption due to tooth mobility. Instead, the goal is to prevent active tooth movement while maintaining the current position. This is the approach we follow. Now, moving to the final topic of today's discussion. This may be somewhat unfamiliar to some orthodontists, but I believe you'll find it relatable. Let me introduce it to you. The goal is to prevent active tooth movement while maintaining the current position.
Wire syndrome refers to a phenomenon where, even though the retainer is in place, the teeth shift to a certain degree. Unlike traditional relapse, where teeth return to their original positions, this involves unexpected movement despite the retainer being intact.
As practitioners, we are often startled by these cases.
I'm sure you, with your experience, have encountered more of these than I have. Patients present with retainers properly attached, yet the root shifts lingually, and the crown moves labially, or sometimes vice versa. These cases are puzzling. For example, a patient recently came in saying their front teeth seemed to be protruding. Looking at teeth 21 and 22, this doesn't appear to be a typical relapse with crowding or spacing issues. Instead, it's a torque problem. The crown shifts outward while the root moves inward. These cases share a common feature: the retainer remains in place, yet the teeth still shift. In some cases, the root protrudes significantly. For instance, the canine in this patient was severely rotated inward. The pattern is consistent. Patients appear to have relapse-like symptoms, but it feels different. While it could be misinterpreted as a relapse due to lack of initial records, the nature of the shifting suggests something else. Here's another example. The root seems to be protruding outward. If you look here, this misaligned tooth is different from the others. This is a patient I am currently treating. While not perfect, orthodontic treatment is helping to correct it through root movement. It may not achieve full reattachment, but the tooth is being repositioned. This patient recently completed treatment, and we managed to align the canine properly. So, what causes this condition? In our research, we frequently came across the term wire syndrome. This is a term mentioned in a recent systemic review journal. Various studies have described it as an unexpected complication or severe complication, with terms like extreme labial movement being used. Although the exact cause remains unclear, the patterns are very similar. It is rare, but in my 10 years of practice, I've encountered about 5 or 6 such cases. And several other patients came in with similar symptoms from external sources. While the exact cause is unknown, our focus has been on treatment. The issue might stem from the retainer itself, the retainer not functioning properly, occlusal pressure, chewing force, or even factors like dental floss or sunlight. These have all been suggested as possible causes. Additionally, factors like gender, age, and other differences could play a role. Often, patients who haven't visited the dentist in 5 years are more likely to experience these issues. Those who return for regular annual checkups tend to avoid severe complications. That's why it's important to encourage patients not to skip follow-up visits after completing treatment. Regular checkups allow us to detect early signs and take proactive measures to address them.
Recently, there are retainer wires made using milling techniques instead of bending, which reduces stress on the wire. These could potentially serve as a useful tip for such cases.
While rare, these situations highlight the importance of periodic maintenance and checkups. I believe this is something worth considering.
I hope today's discussion, though serious, has been informative and valuable. To summarize, there are 2 key takeaways. First, as the title suggests, explaining beforehand prevents excuses afterward. This is crucial not only in orthodontics, but in all dental procedures. Second, orthodontic treatment is a long-term process, so building rapport with patients and maintaining good relationships is essential. Of course, a good relationship should complement skilled treatment, not replace it, but combining expertise with rapport can greatly enhance outcomes. Next time will be our final session of Ortho Barista Season 1, already the 10th.
I remember when we were running around Gangnam Station last winter to get our barista certification.
Who would have thought we'd be making espresso con Panna today? In the next session, we'll discuss minor intraoral surgeries that can support orthodontic treatment. While it's not strictly orthodontic, it's a topic that many orthodontists and general dentists might find interesting and insightful.
I'm really looking forward to it.
We won't be presenting this alone. We'll have a panelist join us to make the session engaging and enjoyable. Shall we end by enjoying a cup of con Panna together in silence to express our thoughts?
How shall we express this?
Thank you. I feel a bit shy sitting next to you.
You've done great. Thank you for your hard work.